All right, my friends. So whenever I'm having a discussion, and thank you very much for joining on Wonderful Wednesdays. Today we're talking about atrial fibrillation, docile or dangerous. Whenever I have a discussion about atrial fib, and I'm so fortunate because I have lots of people from a lot of different venues in care, from the emergency room, from the critical care, and all sorts of different areas. Really important for us to really think in our mind about whether atrial fib is docile or dangerous. Now, similar to ventricular tachycardia, it's typically prodromal, so it's giving us a warning, but sometimes it's not so dangerous, and other times it is quite dangerous. So it's really up to us with our providers at our side, our APPs, our residents and fellows and attending physicians, and all of our colleagues together to actually determine whether the presentation in atrial fib in the patient that we are evaluating is docile or dangerous. So you can see here, we have a really beautiful strip, not so difficult to actually recognize in this rhythm strip that you are irregular and that you have an irregular electrical activity in the atria, which is this presentation. Not always so easy for us to actually know that we have a patient in atrial fibrillation. And if I were to tell you with this patient with atrial fibrillation, if we were monitoring stroke volume and cardiac output, patient has a low cardiac output, normal is 4 to 8, patient's cardiac output is about 3.1. Normal stroke volume is 60 to 100, but the patient's stroke volume is at around 30. So patient is hypotensive, he's poorly perfused, and in that case, of course, we're going to say that it's dangerous. So actually, the visualization of atrial fib as an electrical event is not what is determining whether it's docile or dangerous. It actually is about the hemodynamic evaluation of the patient and how long that atrial fib has been in place. So these are two things that we're always going to want to evaluate. When we communicate to our provider colleagues as bedside nurses, you have to have an agenda. You have to have information all together. You can't just say, I have a patient with new onset atrial fib. We've done 12 lead EKG. Everybody concurs it's AFib. What we have to follow with is that it's new onset and whether or not the patient is hemodynamically unstable. So for me, I'm going to want to look at cardiac output and stroke volume, but if I can't do that, I'm going to try to utilize blood pressure, not always the best thing to really determine acuteness of patients, but a really great thing is how hard did you work to get a pulse ox signal on the patient? Because remember, we're reading pulse ox because of blood flow dynamics. So if I don't have a good waveform in my pulse ox window, that's called the plethysmograph. If I don't have a good waveform in that window, that actually pushes me ahead to actually notify someone that I think that my patient is actually unstable. So I have a lot of good signals at the bedside, and that's what I'm going to use to determine, is my patient presenting docile or dangerous? Now, just as a review, I know everybody here is familiar with AFib and a flutter. Just want to remind you that both AFib and a flutter can be classified as supraventricular. So when you're studying medications, you're taking ACLS, AFib and a flutter fall under supraventricular dysrhythms. Now, they may not be tachycardic because you may have rate control on board, but it's really important to remember anything that works for supraventricular dysrhythms can be something that we'll try for the management of atrial fibrillation or atrial flutter. Now in fib, really, really important, and our focus today is really atrial fib, although we'll take a look at a few patients with atrial flutter. With fib, what's really, really important to remember is that you are electrically activating your atria between 300 and 600 times a minute. Now that's really important when we're talking about atrial fib, because since the atria are fibrillating, there's no concise contraction, which means that you have lost 20 to 50% of ventricular filling. Now remember that the ventricles fill from the atria. So our desire is always to have a good, concise atrial contraction. But with atrial fib, your atria are fibrillating, and just coincidentally, there may be some fibrillation that is occurring and the valve is open. But the most of the time, the valve is going to be closed and you're not really generating enough pressure and not in a normal cycle. So a significant amount of ventricular filling is limited. Now that's really important in terms of understanding the hemodynamic consequence. If let's say I'm an older person, I don't care if you know how old I am. I'm 70 years old. I'm in really good health. I have great heart health. My EF is around 66%. I have a great heart. I have great valves. So only 20% of my ventricular filling requires an actual atrial contraction to squeeze blood from atria down to ventricle. Most of it goes from the atria to the ventricle passively, just down a pressure gradient, just like a slide. Higher pressure in the atria, lower pressure in the ventricle, sliding that blood down into the ventricle. Fantastic. But when we're talking about critical patients, patients who have history of hypertension, patients who have history of aortic stenosis or aortic regurgitation, or mitral stenosis or mitral regurgitation, or tricuspid stenosis or regurgitation, or RV infarct or LV infarct, RV hypertrophy and LV hypertrophy, we're actually requiring more effort on behalf of the atria to fill the ventricle. So instead of being 20% of filling, which will be about 120 to 200 cc's, so 20% of that is 40 cc's if you're at 200. But if you are requiring 50% of filling to come from the atria through atrial contraction, you have reduced ventricular filling by 50%. So when we look at echocardiogram, of course, one of the really important things that we think about when we're looking at an echo is we're actually looking at the ventricular capability to eject a percentage of the volume that is filled in. Now that's really important because two things that affect the ventricular ejection are the integrity of the ventricle and the volume that has filled the ventricle. Okay, so that's really important because most oftentimes we're going to see the most significant consequential marriage here is atrial fibrillation with heart failure. So when you have heart failure and you have a reduced ejection fraction, that means your ventricle isn't working very well. And now you've actually reduced ventricular volume load because the atria isn't contracting because it's fibrillating. You're going to have a significant reduction in the amount of volume that the ventricle ejects. Oh my God, this is so significant. For me, new onset atrial fibrillation in a critical patient is a life-threatening dysrhythmia because I'm so concerned that that patient may not be able to manage the reduction in volume that occurs when you have atrial fibrillation. So again, I want to remind you that the atrial rate in AFib can go up to 600, actually can even go higher, 650, 700. And oh my God, you definitely don't want that fibrillation rate at 600 or so to be communicated down to the ventricle. So the connection, of course, between the atria and the ventricle, which is your common bundle of His, that connects down into your atria, into your ventricle, that common bundle of His protects you. It's refractory to that rapid depolarization. So you're not going to conduct 600 times a minute through that common bundle from atria to ventricle. Typically, you've got a delayed conduction, and typically means that your rate, that ventricular rate, which is not matching the atrial rate, is typically around 100 to 160 beats per minute. Now, that's quite important because that really helps us to define some things, and we're going to talk a lot about this. I want you to really focus on the treatment for AFib. Number one, most important, and not everybody understands that. Not everybody is up with the guidelines or the purpose or the evidence in atrial fib. So it's really important. Number one, control the rhythm. That means the fibrillation rhythm. So you want to control the fibrillating electrical activation as best you can. And we're going to talk a lot about that. Number two is to stop or block a clot because of the alteration in the way the atria is contracting. you may actually have a fair amount of blood that forms and clots in the atria. You may also have a significant ventricular thrombus that really occurs much more naturally in conjunction with some ventricular dysfunction and AFib, and that clot can, of course, break off. Now, we're talking about a clot that then moves into the arterial circulation. So, number one, control the fibrillating rhythm. Number two, stop the clot. Number three, you want to protect the ventricles from that rapid rate. You want ventricular response time to be lower because that's going to be better for the patient. But it used to be that that was number one, but most of the recent evidence since 2018 and beyond is that we should be less worried about protecting the ventricles from the rate and more worried about controlling the fibrillating or flutter rhythm. So that's a little bit of a change in terms of how we think about and look at atrial fibrillation. So just want to remind you that really AFib as well as a flutter, although they have some different epidemiology, that AFib and a flutter are really about chaotic signals. And those chaotic signals in AFib are occurring from multiple areas in the atria that are actually reaching what we call the threshold. Threshold means you open up your doors and invite the ions in. When you invite the ions in, you depolarize, and now you stimulate everyone else. And because we have so many surfaces in the atria that are all reaching threshold, you never have a concise contraction. So that's really important. Those are the fibrillating impulses. So with atrial fib, that's a major issue. With atrial flutter, we have a little bit different epidemiology, and we'll talk about that in just a minute. Now you can see here, of course, very straightforward. Here's your normal EKG with P, QRS, very constant. P to P interval is constant. R to R interval equals P to P. Everything is right with the world. Atria is contracting, filling the ventricle contracts, and hopefully ejects at least 50 to 60 to 70% of the volume that filled it. And you have a good atrial contraction. So as long as your patient is euvolemic, you're going to have an adequate stroke volume. But when you see this with the atrial fib, this is at a rate of around 350. The atria is fibrillating. We're protecting the ventricles from accepting that depolarization. So our ventricular rate is irregular, and it's typically somewhere around here. It's probably somewhere close to 120. And because I'm not adequately filling my ventricles, my stroke volume is going to fall. My patient may decompensate. Their pressure may drop. So these are big concerns for us. So what happens really when we talk about AFib, docile or dangerous? So first and foremost, very important, is that we don't have atrial ventricular synchrony. We are disassociating the atria from the ventricle. Now we're happy for that, my friends, because we don't want the ventricles to depolarize at that rapid rate. But now the atria and ventricles are not connected in a communication style. Atrial depolarization, contraction. Ventricular depolarization, contraction. Here it's our atria fibrillating, and every once in a while, our ventricle contracts. So we are completely dysynchronous. So, lots of times when people talk about AV dyssynchrony, they talk about, heart block, complete heart block. But here you also have AV dyssynchrony. So your atria and ventricles are not firing in direct relationship with each other. If they're not firing electrically, then they are not contracting well, and that significantly decreases ventricular ejection. Now, really, really important for us to always remember is that if you have atrial fib, you have altered ventricular filling. And when you have the atria fibrillating, you almost have lost your ventricular filling time. Now, your ventricles normally fill between the T wave till the next QRS. So when we look at an EKG, we're always concerned about the time between the T wave and the next QRS. But if between the T wave and the next QRS, the atria are fibrillating, then we're going to have a significant reduction in ventricular filling, and that means a significant reduction in ventricular ejection. Now, it's very important to remember that the majority of atrial fibrillation arises from the right atria. So what we know is that atrial fib is directly linked and the preponderance of atrial fib being directly linked is actually related to right ventricular dysfunction. I am so sorry. Somebody is calling me about, I'm sure they're calling me about, we've had a downtime electrically, but I'm not going to be able to answer them. They know I'm on a virtual call, or they should. Okay, my friends. So my watch keeps ringing, so sorry about that. Okay, so really, really important. It also is really important to remember that when you have atrial fib, you can actually have consequential increase in your, if you have a patient who already has heart failure, you're going to have a very consequential increase in patients with heart failure. So just remember, New York Heart Association actually helps us to categorize heart failure from category 1 to category 4. I'm just going to say, if you ever look at a diagram, it's basically from being warm and dry to being cold and wet. So cold and wet is class 4 heart failure. Now, 50% of patients who have significant heart failure, that means they don't have good forward flow, that's why they're cold, and they have backward stasis of volume in the vein, that's why they're wet in the lungs and cold in the periphery. Those patients actually are going to have a significant exacerbation of their heart failure when they're in AFib, which means we're going to pay a lot of attention to atrial fibrillation with everyone, because, by the way, it's bad for everyone. It's bad for healthy people. It's bad for non-healthy people. But if you have heart failure and atrial fibrillation, it's exponentially increasing its badness. So we're going to pay a lot of attention to that, because we're going to be pretty aggressive trying to create a scenario where we can control atrial fibrillation in that patient. So again, docile or dangerous, you have lost what we call the atrial kick. Atrial kick, remember, in a normal heart is about 20% of ventricular filling. That occurs when the atria contracts. Now the atria is fibrillating, and depending on how well the ventricle is filling, if you already have heart failure, or you have a stiff myocardium, or you have valvular disturbance, you're going to have a significant reduction in ventricular filling, which then, of course, will significantly reduce your cardiac output. Now, this is filling. So it's about, when we talk about our ventricles, we're talking about diastolic time and diastolic pressure. If you have a dysfunctional ventricle and it's non-compliant, it becomes much harder to fill the ventricle. As it becomes harder to fill the ventricle, the atria is going to be stimulated to contract more aggressively, but now the atria will be volume overloaded. Bing, bang, boom, you're in AFib. Lots of times, heart failure causes AFib. Lots of times, AFib causes heart failure. Chicken or the egg? Really, I don't think in general, when you're first evaluating patients and you're communicating to your providers, you're saying new onset atrial fib, my patient's unstable, I can't get a pleth, I had one before, now he's in AFib, I don't have a pleth, he's become unstable. I'm really concerned about the patient. I'm giving the evidence to help everyone understand the acuity of the situation. A lot of things will happen here. Most important perspective is that as my atria are fibrillating and I'm having intermittent conduction to the ventricles, I may have some significant ventricular response. So I now have tachycardia. So I already was fibrillating in the atria. My atria were very tachycardic. My ventricles may also be tachycardic, even though they're dissociated. And the problem with that, the most important problem with that, is the faster the ventricle contracts, the less time it has to fill. So I always remind everybody, if I clap my hands, that's systole. And when I relax my hands, that's diastole. So my heart rate's around 62. So it's systole, diastole, systole, diastole, ventricular. Ejection, filling, ejection, filling. But when your ventricle is beating faster or being depolarized more rapidly, what you're actually going to see is syste, 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 syste. My ventricle can't fill, and that is going to worsen my function. And it's going to lead to an exacerbation of heart failure and may even lead to tachycardic cardiomyopathy. So I always call this the chicken or the egg. My purpose as a bedside provider, as a nurse, is I want to be sure everybody has all the information, but I want to understand that it's the chicken or the egg. And really, at this point, it's not so important to say, did the AFib cause the heart failure? Did the heart failure cause the AFib? I'm going to consider both. But what I'm going to see is I've got a lot of volume in the veins, in the pulmonary veins, which means my lungs are wet, in the systemic veins, which means my system is wet. I don't have to be measuring filling pressure, central venous for the right heart, pulmonary artery diastolic or wedge pressure for the left heart. Don't have to be measuring that. What I have to see is by chest x-ray, by breath sounds, that my lungs are wet. By looking at the patient, that the neck veins are distended, that the patient is gaining weight, that he has bilateral edema. That always means an increase in filling pressure. Now, a lot of things happen here. There's an alteration in the way your cells uptake calcium, neurohormonal activation. When you have an inadequate cardiac ejection, you're going to release renin, which converts to angiotensin and aldosterone, which is going to cause arterial vasoconstriction, salt and water reabsorption. Oh my God. Now that's in an attempt to make things better. But if I have heart failure or atrial fib, either one, when I have this normal activation, it's going to make everything worse. It's going to make everything worse. So although I'm not going to talk very much about it today because the new evidence really is most related to heart failure, but actually using ACE inhibition and aldosterone blockers actually can be really helpful to kind of control the heart failure AFib marriage. I want that to divorce. I want to separate them because AFib makes my patient so much worse. So very, very important when I'm looking at those patients and considering this. Now, when we are thinking about our patient population, thinking about our culture within our institution, really, really important to consider incidence and prevalence of atrial fibrillation, obviously much higher in older ages, right? It's almost 5% in ages 70 to 79 and 9% in ages 80 to 89 and continues to go up the older we get because of the stiffer our heart will be. More common to see in men versus women, more common to see in whites versus blacks. But what we want to think about, because you know what, we as providers are not controlling whether you're a male or a female. You may make other choices yourself, and that's perfectly fine. We're also not choosing your race. We can't modify that. Those are things that happen. We can't modify age, although someday we probably will be able to. We can't right now. But we can think about modifiable risk factors. So modifiable risk factors are things like diabetes, blood pressure, coronary artery disease, alcoholism, sleep apnea, obesity. So one of the first things that we think about as bedside providers is we think about how do we help patients control this? How can we help patients limit? I mean, it'd be great to say to somebody, you're never going to have another drink, but I think that's probably really difficult. But we want them to limit any alcohol. And for some patients, they really must not drink at all. We want them to limit their tobacco use. We'd like for them to withdraw from tobacco, but we also have to set skills that are doable, and maybe we have to set steps with patients. If they have OSA, obstructive sleep apnea, we need to be sure they get an evaluation, that they leave our care with some type of methodology, either a mouth retainer or CPAP or even BiPAP, that they leave us with that in order to reduce the incidence of AFib and heart failure. Weight loss, incredibly important. And diabetes, hemoglobin A1C. Remember, your hemoglobin binds to the glucose, and that makes the hemoglobin glycosylated like rock candy in your blood vessels. Really important to remember that our goal is to always get the hemoglobin A1C less than 7. So all of our diabetic patients, doesn't have to be a type 1 or a DKA type patient. Anybody who has sustained hyperglycemia is going to be significantly at risk here. Obviously, the new guidelines for the heart AHA and the National Hypertensive Council is we'd like to get your blood pressure below 130 to 180 at rest. And that's really important. And here's another place where ACE or ARBs, angiotensin converting enzyme inhibitors or angiotensin receptor blockers come into play. Remember, ACE inhibitors always end with the words pril and ARBs always end with the word sartan. So that helps us to understand if our patients are on appropriate therapies. And of course, last but certainly not least, exercise. So when we look at this list of risk factors, many things here we cannot alter. We cannot really alter whether or not you had open heart surgery before. We can actually control thyroid disease. We can help control diabetes, high blood pressure. We can help to control sleep apnea and obesity. Excessive alcohol or stimulant use is really up to the patient, but they need to really understand what the purpose of that is and why it's so important. So now we move to the pathophysiology, which I think is incredibly and profoundly important when we talk about the correlation of the different kinds of electrical signaling that occurs that causes atrial fib or atrial flutter. So normally, remember, we have a wave of current, depolarization, that moves through the atria, and the atria responds with contraction. So we have a single signal that's been deployed throughout the atria. One single signal actually recruiting the atria into atrial contraction. Fantastic. That's normal. But when we talk about atrial fib and when we talk about atrial flutter, we can have some really significant alterations. One of them is just organic and structural. The other is that we may have a low-hanging fruit off the AV junction that you see right here. Here's the common bundle of this. We may have a small branch here that actually will conduct in a backwards direction. That's called a circus reentry. We also just can have unstable atrial tissue, meaning it's not well oxygenated or the electrolytes at the cellular level are imbalanced. And we can have multiple activation of our atria in that relationship. So it's really important to recognize that the primary cause or stimulus for atrial fibrillation is cardiac. It's cardiac ischemia, it's cardiac dysfunction, cardiac electrical abnormality, cardiac abnormal structures, and valvular dysfunction. But there are other things as well, and we should always be paying attention to this. Okay, so you see the word pirates. I wish this was my idea. It's not. Pulmonary embolus, ischemic heart disease, rheumatic valve disease, anemia, thyroid disease, elevated blood pressure, sleep apnea, and sepsis. Pirates. That's a great mnemonic. So we're pirating away the function of the heart through some are cardiac, but mostly non-specific disorders that are actually recruiting our atria into dysfunction. Now, I'm going to tell you one of the ones that I am most concerned about, and I think we don't always explore, is the patient who presents with hyperthyroidism. And really important to remember that in a thyroid crisis, even if a patient has been treated, but if they have a thyroid crisis or undiagnosed hyperthyroidism, one of the first signals for that patient is actually new onset atrial fibrillation. So I love this idea of having a mnemonic and just reminding ourselves that we get patients into our emergency department and we have patients in the ICU who all of a sudden go from a relatively normal sinus or maybe a mild sinus tachycardia without much atrial abnormality, and all of a sudden they're in atrial fib with rapid ventricular response. That didn't just happen. There's a causative reason for it, and we should work through those causative reasons. I'd say for my practice, most important would be pulmonary embolism, pulmonary disease, and undiagnosed hyperthyroidism. So I'm going to really think about that. I want to actually be able to talk about what might be causing these issues in the formation of atrial fibrillation. Now, pretty straightforward symptoms. There are symptoms like all cardiac symptoms. You get tired fast, you're short of breath, you feel your heart is palpitating, you have exercise intolerance, you might have discomfort in your chest, you feel dizzy, you feel lightheaded, you feel like you're going to faint. And typically, you have increased urination at night because when you lay down, more volume gets returned to the heart. So those are all symptoms that we're considering. But what we look at the bedside, really, really important, really, really important. We should be looking at the jugular veins, because what we typically are going to see is the veins are engorged, and our veins are pulsating, which is not really normal. Your veins always pulsate, but typically at the bedside, we don't see that. It's really a minor level pulsation. So that's going to be really important. Patient may have a pulse deficit when we do a comparative analysis of right to left. They may not have any peripheral pulses because they're conserving blood flow and vasoconstricting. If we have a methodology, look at stroke volume, we might be doing that with a Starling on the chest with a flow track transducer connected to the A line, but we also are able to look at that by just utilizing basic pleth monitoring. That's the pulsatile waveform that's associated with your SpO2. When we look at the EKG, what we're going to see is short, long R-to-R intervals. That's the irregularity. And when we're feeling the pulse or looking at the pulsatile quality on our monitor early on, we're not treating the patient, you will be quite irregular. And it isn't a constant irregular like you see with a type 2 Winky Bach or other kinds of dysrhythms, really probably type 2 Winky Bach being the most significant one. This is going to be profoundly irregular, completely unpredictable in terms of ventricular response. So we're going to do a lot of investigation. Our providers are going to say we need an EKG, we'd like to do a stress test, or we're going to do an echo. Patient's acute, we're going to do an echo in the bed, we're going to do a chest x-ray, and we're going to do some blood tests. So those are all really important and standard perspectives. From that, we move to really being able to diagnose the patient. Now, what I want you to understand here is everything that's abnormal here, not the ventricular ectopic, but flutter, AV nodal reentry, fib flutter, and multiple PACs or atrial tachycardia. Those are all supraventricular tachycardias. Typically, I say that folks use the word supraventricular tachycardia when they're uncertain of what the origin is. What we want to do is find out what the origin is. Is it afib? Is it a flutter? It's a little harder for us to actually at the bedside say, oh, it's AV nodal reentry, which is that kind of that little stalk that sticks down, that's anomalous, that conducts in a backwards direction, what we call retrograde or reentry, back up into the atrium and down to the ventricle, and it's in a circle all the time. It's a little bit harder for us to diagnose that. So we should make really focused, significant evaluation. We should work hard on the diagnosis and the understanding of differences in AFib, a flutter, multiple PACs as prodrome to a multifocal atrial tachycardia or AFib. So lots of times when I'm having discussions, people will say, well, your patient's having multiple PACs, and they're like, nobody cares. They feel like that's innocuous. Well, it's innocuous as long as it doesn't progress. Just like you look at multiple PVCs and you look at bigeminy or trigeminy or multifocal PVCs as being prodrome for VTAC, and you're all over that, but we don't really look at multiple PACs or multifocal PACs looking at different P wave formations as being prodromal for atrial fib, because in general, we don't think about atrial fib as a dangerous dysrhythmia, but it can be very, very dangerous. So now we just take a look in comparison from AFib, and of course, these are real patients, but you know, they've been chosen to be in a visualization because it's really profoundly evident, right? Here's AFib, it's irregularly irregular, and the baseline is quite wavy. Here's a flutter. Remember, the best way for you to diagnose a flutter is turn your strip upside down. If the atrial looks exactly, the atrial depolarization looks exactly the same, right side up or upside down, that's probably atrial flutter. Multifocal atrial tachycardia means that you can't see evidence of AFib, but you are irregular. And when you look closely, you'll see that you have P waves that you can see extraordinarily here, sometimes buried in the T wave. But you also have P waves that have a little bit of a different perspective. See, this one is a little tenty. This one is more pokey. So usually this is multifocal atrial tachycardia. Here's what I'm going to advise you all to do. So pay attention. At the bedside, when you're trying to actually evaluate your patient's EKG at the bedside, go up there, touch your waveform, your EKG waveform, toggle down to change sweep speed. Put your sweep speed at 50 centimeters perspective. And what that means is now all your waveforms are going to be spread out over a longer period of time. And from there, you can almost always see what the problem is. That is really important. Now, you got to let people know you're doing it because they're going to think the patient's really bradycardic now. Just let them know you're changing the sweep speed and don't leave it at 50. But that is one of the best diagnostic methodologies for looking particularly at atrial dysrhythmias so that you can separate your fib waves and flutter waves and your multifocal atrial tachycardia waves. Okay, now in a reentry, a nodal reentry, the P wave typically occurs after the QRS because that electrical activation in the ventricle is going in a retrograde or reentrant method through that little stalk that doesn't have all the confines of the AV junction, and that's what basically creates AV nodal tachycardia. Let me make sure you understand something, and that is nobody is going to hold your feet to the fire and say, well, you said it was AFib and it's a flutter, or you said it was multifocal atrial tachycardia and it's AV nodal reentry. Everybody is just happy that we're all paying attention to the patient, looking at abnormalities. We're not always going to be right in the diagnosis. You could be a cardiologist. Probably if you're an EP cardiologist, you're going to be right almost every time. But as a regular cardiologist or an interventionalist, you're going to be incorrect many times when you're diagnosing dysrhythmia. It's okay to be incorrect. What's not okay is to be unaware. We got to be aware that this is happening at the bedside. So when we talk about AF and we talk about atrial flutter versus atrial fib, really, really important to remember that AFI, which is atrial flutter, is a large atrial dysrhythm that occurs from a reentry circuit. So actually therapeutic intervention may be different for a flutter than it is for AFib. AFib is typically, you have all these little wavelets, all these little areas in the atria that are depolarizing all the same time, and it makes a hodgepodge. It's chaotic. It's not good blood flow. It's not good contraction. And that is really, really important because with a flutter, I may have better control of my patient. A flutter does not respond to synchronized cardioversion, my friends. A flutter does not respond to synchronized cardioversion. AFib, especially new onset AFib, typically is going to be quite responsive. A flutter is typically not responsive to cardioversion. Okay, so when we think about a flutter, it's also really important to look at kind of this contiguous atrial activation that is really reproducible. Remember, right side up, upside down, you're going to see those sawtooth patterns, and the rate of that atrial depolarization is much lower than the rate in atrial fibrillation. So really, really important to remember that. And typically when we look at patients, we see a 2-to-1 AV conduction, 2 flutter waves to 1 QRS, which then can vary with 3-to-1 AV conduction, 3 atrial wave to a QRS, sometimes 4-to-1 conduction, 4 atrial waves to 1 ventricular response. But really try to ignore the QRS. Remember, go to your bedside. I know I've got some APPs on here and I'm so thrilled. Go to the bedside, touch the waveform, and put it on a 50 sweep speed. This will allow you to really focus on the atrial pattern. So you can say this is SVT, but you're trying to actually evaluate what form of SVT it is. And I want to remind you that these re-entry dysrhythmias do not respond well to cardioversion. Doesn't mean you're not going to try it. Just don't expect that you're going to see a significant response. So this is a patient with atrial flutter and a 4-to-1 response. Okay, and you can see those flutter waves. Now, might have been that at the bedside, some folks might have said, no, I'm not sure. Is it fib? Is it flutter? But if we turn this patient, we turn this EKG upside down, which I'm going to do right now. Okay. What you're going to see is the waveforms look exactly the same, correct? Everybody can see that. I turned it upside down. I still see those flutter waves just like I did before. And that's really a great diagnosis. If I'm having trouble, then I'm just going to go forward and I'm going to go in the room and put you on 50 sweep speed and really look at those waves. This one is a little harder for us to diagnose. This is atrial flutter with a 2-to-1 response. Now, your ventricular response is absolutely regular. And it's really only with a very astute eye that we can actually see This is flutter 1, flutter 2, flutter 1, flutter 2. You might have looked at that and said, well, I thought that was the T wave. But actually, again, when we turn it upside down, it's going to look exactly the same way. So with a 2-to-1 response, it's much harder to diagnose. Here, you have atrial flutter that goes between 2-to-1, 3-to-1, and 4-to-1. If every patient presented like this with atrial flutter, it would be much easier for us to diagnose that patient. Here's another patient with atrial flutter who also has some ventricular hypertrophy. This is LV hypertrophy and also a bundle branch block. So that makes it really hard for us to evaluate the patient. We go in that room, we're like, this looks really weird. Is this ventricular? What's going on? But this is, again, atrial flutter with a variable ventricular response. And we have atrial flutter in a patient who also has a stiff left ventricle and has left ventricular hypertrophy. Okay, now let's just take a quick look at an AFib diagram. AFib, it's exactly what we looked at before, is electrical chaos in the atria, occasionally conducting down into the common bundle and into the ventricles, but it's not reliable. And a lot of our history and a lot of our careers and a lot of our medication has been focused on controlling heart rate. Because, remember, you've got this very rapid atrial rate, but you want to control your ventricular response. So rate control has been historically a really, sorry about that, I'm right in front of a firehouse. And they're very busy here. I'm in Chattanooga on my way to Cookeville, Tennessee. They've had a lot of things going on, I guess a lot of lightning strikes. So here we go. We just remember when we're looking at this patient that on the new onset patient, we're going to see an irregular. So irregular ventricular response. Short, long, medium, short, medium, long, medium, short, all looking at that variability of ventricular response. There are no P waves. We should not be calling those P waves. They are not P waves. They are fib waves. And those fib waves can be really fine. So it can be very hard for our EKG system to actually tell us that the patient's in atrial fib. We should never really rely on the electrical interpretation of our computers. They are just not yet as advanced as we need them to be. But you can see this patient it's a relatively discrete irregularity here. And you can see that wavy baseline. And again, I would always go with that patient, I would always go to the bedside monitor and put them in 50 sweep speed. Sorry, I'm going to take a quick pause. Okay. So really, really important now as I look at atrial fib and I'm looking at that undulating baseline and the irregularity of ventricular response. Same thing here. These are oftentimes very easy to miss. And remember, what you want to do when you have these patients is you want to get to the bedside and look at whether or not you can make a case for stasis of volume in the veins, pulmonary veins, desaturation, chest x-ray looks a little more wet, neck veins are distended, you've got bilateral edema in the peripheral extremities. Make a case for the patient being wet. Now, there are a couple of different terms that we use for AFib. They're really not that important to us, but they are just help us to define the types of AFib that our patient is going to see. So I'm going to do this really quickly. Paroxysmal means that a patient had a rapid onset and a rapid offset. So typically their AFib lasts less than 7 days. Persistent is chronic. It stays around. It doesn't terminate within 7 days. Permanent means that you've been in AFib for at least 1 year. And you have either not ever been cardioverted or there was an attempt to cardiovert you and it failed. Lone is typically seen as a one-time onset of AFib, typically seen in younger patients. So we just compare the terminology. That may affect what our colleagues and our providers want to do to actually treat our patients. So really, really, really important. So our concerns for patients are, of course, that if you have AFib, it may propagate heart failure. If you have a heart failure, it may propagate AFib, and it really may actually correlate to a worsening quality of life and increased mortality. It's really significant. That's why it's disastrous and dangerous. So we just divide our patients into two groups. hemodynamically unstable. If you are hemodynamically unstable, you're going to get cardioversion. And if there's time and willingness, you're going to get sedation. But I'm not going to withhold cardioversion if you're hemodynamically unstable if I can't sedate you. I want to sedate you, but if I can't, I won't. And then we're going to think about adding in medication. Those are going to be either sodium channel antagonists, that would be ibutylide or procainamide, or potassium channel antagonist, amiodarone. If you're more stable, now I'm going to step back because I want to evaluate you a little bit more. I want to control your rate, but I want you to be anticoagulated, okay? Because if you're stable, this is typically not an acute condition. Acute conditions typically present with some instability. So this is a little bit more worrisome in terms of clot formation. I'm always going to ask for an EP, and I'm going to consider that you really should be in a cardiac unit where you're going to get cardiac monitoring. And of course, we're going to completely evaluate the patient and try to rule out secondary causes. So I'm going to end here because I'm aware that I've gone 5 minutes over time here to just say complications here. What we're concerned about, what's so disastrous is exacerbation or introduction of heart failure into your life. Heart failure is a disastrous disorder that really limits your quality of life. And the second complication from AFib is, of course, stroke, which is devastating and can be profoundly devastating. So remember, therapeutic intervention. Number one, I gave you that little box before. I want to control your rhythm. Number two, I want to control your clotting. And number three, and I'm not always going to consider that, would be that I have a desire to control your rate, but it's the least important, not the most important, okay? Really want to get at what is causing that rhythm so that I can prevent stroke, so that I can prevent cardiomyopathy, and I want to relieve your symptoms. I want you to be able to breathe. I want you to be able to exercise. I want you to be able to walk. And that's really, really important. So deciding what's next, rhythm control, rate control, thromboembolic risk prevention. So next week, I'd like to continue on this. I'm going to have about 5 or 6 case studies, and we're going to look at our drugs of choice, what we're going to do, how we've evolved from 2014 to 2016 to 2019 to 2023 in terms of what we want to do to help control atrial fib, because in the older days, even 5 years ago, maybe even in your unit yesterday, atrial fib has been treated and assumed to be relatively innocuous, but it actually is a very, very dangerous dysrhythm. So I hope you'll join in next week for this part 2 of atrial fib, docile or dangerous, case study focused, really looking at the guidelines and what we can do, and also what we as nurses, as bedside nurses, along with our providers, should be doing and evaluating at the bedside. I want to say thank you so very much for joining today for Wonderful Wednesday, part 1, atrial fib, docile versus dangerous. Hope to see you next week on Tuesday topic and also on Wonderful Wednesday. Thank you very, very much for attending today, and I hope to see you again very soon.